Apologies for absence. We've got two, is Veronica Jones and Councillor Humphreys and Rebecca Wilczaks. Okay. Minutes of the previous meeting, just to be noted. Have we read them and agree them?
Move acceptance.
Okay, thank you. Can I remind members of the declarations of interest? And I'll go straight on the forward plan.
Thanks, Chair. There's two items on the forward plan that will be coming to this committee. That's the market position statement, which will be coming to the next meeting, and the recommissioning of drug and alcohol services, which will be coming to the meeting in December.
Okay, thank you. The next one, we're going to go straight into the post-COVID pathway and activity, and that's Alistair Bell and, number 5, Minister of the Health and Wellbeing Board. Can we agree them as a true record, just to be noted? Yeah. Okay, thank you. So number 6 is the post-COVID pathways and activity in Northumberland, and that's going to be presented by Alan Bell and Alistair Blair.
Thank you very much, Chair. I'm Alistair Blair. I'm one of the Exec Medical Directors at Northumbria, but also clinically a GP. It's a really welcome opportunity to come and talk about this. It's an important issue. I think for a long time when we were grappling with COVID, which was a new disease, there was a lot of worries about the implications of long COVID and whether or not that was going to be a whole set of new pressures. I think hopefully you'll see through the presentation there's been a lot of work done on this, which can be individually really life-changing for some people, but it's also in line with, unfortunately, quite a lot of other significant infections that we get. So the recovery pathway has probably not proven to be as novel as the new disease itself. On Dicey, we've got Mark Weatherhead, who's one of the consultants who actually leads our post-COVID clinic. And it's important to realise that there is a definition of post-COVID or long COVID, so that most people in the weeks after COVID will feel a little bit lethargic, but this is a defined population of people who have gone beyond at least 3 months after their COVID infection with ongoing persistent symptoms. So what we'd hope to do is to go through the presentation, give you some of the facts and figures, and then be really keen for kind of collective questions.
Okay. Thank you.
Thank you, Alistair. So, yes, just to start off with, from a regional perspective, we actually have a post-COVID group, and that's got a number of focuses. One is to just share the learning around post-COVID across the region and across the trusts. So our partners within Northumbria and Northumberland health professionals are part of that group. And as part of that group, we also make sure that we're sharing the national guidance on anything related to post-COVID. So there was guidance released the back end of July of this year, just to talk about in terms of making sure that pathway is consistent across the region, making sure it's integrated with all of the different services, also making sure that referral criteria is consistent, and ensure there's a multidisciplinary approach to that, including that rehabilitation element. I've just got some data slides now, so if I click onto the first one. So if you look at this graph, so Northumberland is the blue bar. So you can see this is a monthly representation of how many clinic contacts there are within Northumberland for Northumberland patients. It also includes North Tyneside patients as well within there. As you can see, from when the clinic was set up around 2 years ago, there's been a very small number of patients through that. So if you look on the left-hand side, on average over the last year, there's around 20 to 25 patient contacts on Northumberland residents being seen within Northumbria Healthcare Trust. So the next slide just shows the age profile or the number of people referred in. So again, Northumberland is the blue bar there. That also includes, or this graph includes, North Tyneside and the North East and North Cumbria as a representation. So from that graph, you can see that the majority of patients are between that 30 and 60 year age range, and that's consistent and comparable across the North East and North Cumbria. So the next slide is just comparing the average age of the patient overall into the clinic. So as you can see, there's no real deviations across Northumberland, North Tyneside. So the average male into that clinic or referral is around 57 years old, and for a female that's 51 years old. So the next slide just shows the number of referrals by deprivation score. So this scored from 1 to 10, so 1 has been the most deprived across Northumberland and 10 is the least deprived. From this graph, the number of referrals in the population, it shows that actually potentially the more deprived areas have more referrals in for post-COVID, and the less deprived areas have less referrals in. I think that completes the slides that I've got. Pass it to Mark.
Right, thanks. I'm Mark Weatherhead. I'm one of the respiratory physicians, but also involved in a post-COVID clinic. So just going to talk a little bit about COVID, post-COVID, and how it links into the clinics and what we're seeing. COVID itself, as everyone's probably aware, is a game of quite a lot of multiple phases. Before autumn 2020, actually outside of the hospital, confirming the diagnosis was quite limited. There wasn't PCR tests. There's not a definitive test for past COVID infection. The mass testing obviously sort of came in through 2020 and into the end of 2021. And at the moment, ongoing more limited access to testing outside of the hospital. There's a huge number of symptoms associated with long COVID, post-COVID syndrome, over 200. It is slightly more common in women. The majority of those, if you look across the country, is between about 30 and 50, slightly more when you get into the clinics, in slightly older. It's no link to severity of initial infection. The vast majority of people we're seeing in the post-COVID clinics are folks who had milder infection who did not end up in hospital or did not need to seek medical care to start with. And there's a huge emphasis in terms of the management of it, in terms of listening, excluding other things, and actually understanding and believing people's symptoms. So I'm going back the other way. In terms of numbers affected over time, there's a lot of stuff collected by the Office of National Statistics, and about 21% of people who swab positive have symptoms about 5 weeks, about 14% have symptoms at 12 weeks. In terms of us defining someone as having post-COVID syndrome, we're saying that's symptoms at 12 weeks, and I will tell most people that I expect it to take about 3 months for someone to fully recover normally from a COVID infection, even if it's mild, in terms of the fatigue and the breathlessness after that. The biggest group of symptoms going on are the fatigue, the brain fog, the headache, the breathlessness and chest pains, and there's some distinct groups of people who do get slightly different symptoms. There's quite a lot of the symptoms that you get with post-COVID syndrome are quite common in the population. So actually, if you do surveys looking at symptoms, there's quite a lot of it in the background that overlap. So probably, if you look at overall, about 3 to 4% of people who've had COVID end up with symptoms going beyond 12 weeks, and what we would say is sort of post-COVID symptoms and post-COVID syndrome in itself. It seems to be a bit more common pre-vaccination and with the original COVID variants. The later versions, the Omicron, seem to have generated less long COVID, post-COVID symptoms. And there is some evidence that being fully vaccinated reduces your risk of developing it in the first place, not only of catching COVID, but of developing sort of post-COVID symptoms afterwards. Nationally, when they looked at it, they reckon there were probably about 70,000 patients whose symptoms lasted over a year. That equates to just over 500 between Northumberland and North Tyneside. I think it's difficult to know how accurate some of those predictions are, and I think we're looking at slightly more lower end of the spectrum nowadays in terms of that. We originally set up post-COVID clinics in the Trust in May 2020, initially to sort of follow up the folks who were discharged after having very severe COVID infection and then picking up those being referred in from primary care afterwards. And it's been largely run by respiratory physicians with input from our physiotherapists and psychologists and the multidisciplinary team. The main thing in terms of investigating for post-COVID syndrome is really excluding other things. There is actual medical treatment for symptoms are limited, but what you don't want to do is miss something else serious going on, and that does need to be picked up, and acting acutely will very much change management. So part of what the assessment had done in primary care and in the clinics is making sure there's nothing else going on. It is a little bit of a diagnosis of exclusion, and at present management of long COVID, post-COVID syndrome is very much symptomatic. It's a combination of reassurance, of advice, of physiotherapy, psychology, rehabilitation input, and a lot of reassurance. The vast majority of people will get better with time, but we know for a lot of people that time can be months, 2 years, and a very, very frustrating amount of time. And it's trying to help support people through that and sort of cope and manage in terms of work and life. So there's an awful lot of research going on, still looking at things and what can be done beyond that. And I'm sure in a year or two we will find out a lot more. Whether we'll find out anything else we can assume to treat it differently is the bit we don't know. But at present, it's very much managed akin to chronic fatigue syndrome, very much support, very much excluding something else, and very much just trying to work through with individual patients and trying to support symptoms as best as they can. As Alan said, regionally, there has been funding put, and nationally has been funding put together to support post-COVID services. What's not clear is the long-term funding, and it's all been delivered year on year and bit so far, so we're not quite sure what's going to do longer term. There are still some areas for a small proportion of patients, particularly those who need long-term rehab and particularly occupational therapy related rehab, where there is certainly a shortage on a regional basis because it's very specialist treatment that's not been needed in the past, and that's a bit that certainly the regional groups are looking at how they can develop that for that very limited group of patients, and that's still being explored on a regional basis. That's all I've got to say. Any questions?
Any questions from any members? Yes, Georgina.
Thank you. I've got 3 quick questions. Is that okay? So the first is just on something you said, which is on page 10. There is evidence that being fully vaccinated reduces your risk of developing long COVID. So am I right in presuming the evidence would be, 5,000 people who've had COVID and they've got long COVID, and 5,000 or whatever, a decent sample who haven't had long-term symptoms? There's a higher percentage of those in the latter bracket who are vaccinated than the former.
Yeah, I can't give you the exact figures, but certainly if you look at the population group, there's lower evidence in getting COVID in the first place than the vaccination. That's the biggest gain. But there does seem to be on top of that, even in those who get it, a reduced risk of having long-term symptoms if you've been vaccinated.
And I presume you don't mean that if you had long COVID and had 2 jabs, that if you then, the symptoms were reduced if you carry on have vaccinations, that I'm presuming wouldn't have any effect?
I don't think there's evidence one way or the other for that. You certainly hear anecdotal things from people that sometimes we...
You do, right?
Yeah, but you hear it slightly either way. So I have got patients who, for the vaccines, they feel their symptoms have improved, but I've got 1 or 2 who things have clearly flared. So it does seem to be a little bit varied, but you'll hear both from people.
Okay, and just, has there been any research or work done looking if there's any link to ME? Because ME is the chronic fatigue, isn't it? Which is kind of like a collection of symptoms, a bit of a mystery. All you know is that people are feeling exhausted, something's happened with their immune system or something. Is the same sort of thing happening? So
there's a lot looking along similar lines. So if you look at ME, chronic fatigue syndrome, if we'd gone back 5 years ago and had people presented with symptoms we label as post-COVID now, we would be calling it chronic fatigue syndrome or ME. It's the same symptoms that you get in a lot of ME, chronic fatigue syndrome, you get after viral infections. So there is a lot of thought that a lot of the symptoms do overlap, and a lot of them are very similar. There are some things that are a bit different about post-COVID, but a lot of it is still thought to mirror along the very similar lines of ME, of chronic fatigue syndrome, in that it's that sort of ongoing response after a viral infection. So there's research going down various different streams, some of it looking along that, some of it taking it separately. A lot of what we're currently doing in terms of the management and the advice on the exercise and the psychology input and the rehab input and the sort of the pacing and stuff is based on what people have been doing for ME and for chronic fatigue syndrome for many years. So the basic background management is based on the same, and there's a big overlap.
I think it's fair to say there's also an overlap with people who get very severe influenza, end up often with a particularly chronic fatigue for an episode. And if we look at people who have, for example, severe sepsis who are coming in, they will often have a very long, prolonged recovery afterwards. So there's quite a lot where the immune system, the recovery from other diseases, is not necessarily the issues being unique to purely COVID.
I think a lot of it is that we've just had so many people infected with COVID compared to what we usually have in a year. It's just a mass appeal with symptoms.
Okay, Councillor Dodds.
Yeah, the deprivation figure, could that be construed as rural v urban? You know, if I went to an urban area, I'm much more nearer lots of people, whereas if I'm out in the sticks, stroke smaller towns, I'm less likely to see people or meet people or what have you. Is there a urban-rural link, or does that not exist?
I think the data, I mean, we've got very deprived rural communities in Northumberland, some of the coastal communities as well. So I think the data is probably more about deprivation than the rural-urban split. We haven't specifically looked at the rural-urban, which we certainly could do if that would be of interest to us. But a lot of our, you're right that Ashington, Blythe and some of the areas are more dense populations, but if we look at the former mining communities on the coastal belt, they've also had disproportionately large numbers referred.
Thank you. And just thinking of the post-COVID, you know, that weakens the body, so that will make them more prone to picking up other, you know, like the influenza and these other sepsis and things like that. So would that possibly extend the post-COVID? I know it's a guessing game at the minute, but
yeah,
you know, we're going into that season of the influenza and that. So I'm just wondering if with the weakened system is going to allow them to possibly pick up other things.
Again, it's all anecdotal side of things rather than evidence-based. But yes, again, you do get the stories from people that, yes, they do get more knocked back by the other infections. I don't think there's necessarily evidence that you are more likely to get anything else, but obviously if your general health and how you're feeling is not as good, even if you get a less severe infection, it's going to make you feel worse, and it's not knock you back that much more than if you are fit. So I think it's probably much more likely to be that effect in terms of an infection, someone who's not as fit, rather than the greater risk of getting things.
Derry?
Thank you. Debbie Nugent, Health Watch Northumberland. Just a question. In one of the slides you talked about signposting to services. I think it was for self-help, psychology and physio. And I just wondered what that actually means and what reflection or experience you've got about how people take that up and how that works for them.
Yeah, so there's a mixture of things. So for the folks that we are seeing in clinic, we've got linked physiotherapists with them and pass through to see, and linked psychologists, both within us and within the community services that we'll refer into. There's also a whole host of some fairly good online resources and bits nowadays. So for folks who aren't being directly inputted into from clinic, there's a couple-page leaflet linked to online resources that tend to send out with letters to signpost. Now, everyone is variable at taking them up in terms of that. Some of it does link to motivation and interest and belief. Equally, there's a programme put on by the English National Orchestra nowadays looking at singing therapy for COVID, which some people, again, very much take up and like when you refer into, others don't. So there is variable uptake. It's obviously much easier if you can catch someone on a day and do it, but then it's beyond the individual intervention as people carry on with things, because it is a long, slow and sometimes frustrating time. from personal experience, I can understand that.
The other thing I'd say about signposting is not everybody with post-COVID is being referred to the clinic. There are quite a lot where once other serious conditions have been excluded, when the psychology and respiratory physiology have been offered, they are looking at yoga or looking at other treatments themselves on the understanding that they're not missing out on a specific medical cure for it. And I think signposting has meant that a number of people have said, well, actually, that's probably not for me, but my understanding of the condition and those aspects means that not everybody is necessarily going through to see the post-COVID clinic, which is probably to be welcomed. So it's actually appealing to people who already know the offer that is there for them, rather than it being presented as here's a curative treatment rather than a process which you may or may not want to embark on yourself.
Councillor Bowman.
Thank you, Chair. Can I talk about mortality rates? Post-COVID, the mortality rates nationally in the United Kingdom have increased. Are you looking at the mortality rates as well? Because people with post-COVID symptoms are part of that. Are you taking that question into your reports as well? I don't know if you're aware, but the mortality rates have increased over a period of 5 years by 17%. It's very significant. And it's also worldwide. The World Health Organization is looking into it as well. Are you looking into that as well as part of your reporting?
I can probably pick that up. It's not viewed as part of the post-COVID clinic mortality, but the Trust is looking, as indeed are other sectors of the health, particularly excess mortality across Northumberland almost on a weekly basis. So we're tracking the excess of mortality, and there have been significant peaks, particularly during the first 2 waves of COVID. There has also been some troughs, so that locally we've seen that actually for large parts of this year, mortality has actually been under the expected rate, and as we expect, but we are keeping an absolute watching brief on that, and I get weekly figures on our excess mortality, and it is the excess that's, as you've rightly alluded to, that's most important. At the moment, certainly across Northumberland, this year we do not have a significant excess mortality, which is reassuring. We need to wait and see what happens with winter, and I think we are also anticipating within that the epidemiology suggests that influenza will be probably more marked this year than it has been for 5 years, and that always has a factor in on mortality as well. But it's a good question, and we are absolutely tracking it.
Councillor Chicken.
You were talking about signposting and so on. I'd like to know how your interaction with GPs in terms of that, because I have a number of clients that I see privately who are displaying symptoms of long COVID, have been to see their GP and have had zero help from the GP. One client of mine actually reported being told by her GP that he was just a man listening to her story and offered zero help at all, no signposting, no effort to connect her with clinics of any type, or even explain to her what her symptoms were and how she could alleviate some of those. So I wonder how well GPs are aware of these services that actually sound pretty good to me. Is there better communication that could be had with GPs so that they can signpost patients onto that and get them the help that they require? Because at present it doesn't seem like that is always the case. Thank you.
I can't speak for all GPs, and Alan may be able to come in, but certainly there was a lot of communication and education that went out, and if we look at the adoption of the recommended tests and things, the levels of uptake are actually quite high across Northumberland. So all I can say is that on aggregate, the guidelines appear to have been very well followed, and we are getting a lot of people being appropriately worked up. Clearly, it sounds like you've got an individual whose care wasn't as good, but certainly from the figures, there was a lot of initial education, there was a lot of good linking, and I think also with advice and guidance where GPs are often able to discuss these cases directly with respiratory, who've sometimes said, well, if
Yeah, so absolutely. In terms of that education, it was rolled out across the whole of Northumberland, and we expect all GPs to be aware of that. I'm happy to pick up separately that individual case, and then if there's more educational support we can offer to the individual GP practices, very happy to do that and pick that up.
That would be brilliant. Thank you.
And just to link in, the education's ongoing, because in about 3 weeks' time there's another GP education event which I'm talking about, post-COVID and long-COVID Act.
Okay, thank you. That helps.
Okay. Okay, thanks for that. Is there any other questions? None? Okay, can I just thank you very much for the presentation, and let's hope it's not so bad with the winter's coming, because we've got influenza and the COVID together now. So, but thank you very much anyway. You can stay or you can go. Thank you. The agenda is the home care, and we've got Gillian Finn and Marion Dixon here to do a presentation. Over to...
Yeah, so my name's Gillian Finn, and I'm the Operational Services Manager for Home Care and Care Homes, and I'll be giving an overview of Care Northumbria. Check you know how this works. Yeah. Okay, so Care Northumbria is a new domiciliary care service from Northumbria Healthcare Trust that will offer support with personal care to people in their own homes. The service will be commissioned to provide services in Northumberland and North Tyneside, and will be allocated work through the usual local authority commissioning processes. The service will support people to return home from hospital with care when they need it, and also people who are at home that have care and support needs. It will help them as well. The service will provide capacity to the sector with the aim of supporting where there are gaps in current provision. So in terms of why we need to do Care Northumbria, so across both local authority areas, there are a substantial number of care hours per week that are not being delivered. So it leads to people either waiting in hospital for packages of care or moving to step-down units while they wait for a package of care. With that come some risks that they can become dependent on services and reduces the opportunity for them to be able to return home. So we want to be able to provide packages of care when people are ready and when people need them, and to reduce those risks. The care sector has had a hard time recently and is under pressure, and we want to deliver high quality care and ensure that carers are valued in their role. And just in general, for us, it feels like this is the right time to do it. So far, we have added personal care to the Trust's CQC registration. We have recruited a registered manager to run the service. We have agreed the staffing structure. We have put a phased recruitment programme in place. We have developed an induction and training programme that is specific to the home care assistant role that we haven't had before. The communication strategy in place. So you'll see on the slide that we have the Care Northumbria logo. So we do have the whole communication strategy in place, and we are going to release more communications as the service mobilises further. Whilst we've been doing the development, obviously we have faced some hurdles. So domiciliary care, you can imagine it's a new area of work for the Trust. So we have had to sort of try and get our head around what that means and what we need to have in place, and to come at it as a provider rather than a healthcare trust. We are trying to provide support in a way that doesn't destabilise or threaten existing provision, but we do recognise that some disruption is likely. The financial modelling and financial viability is also a challenge. So our staff are employed directly by the NHS, so they are on NHS terms and conditions, and they are part of our organisation, and the service is being paid at the prevailing market rates. Sequencing and mobilisation speed has also been a challenge, so to have everything that we've needed in place when we've needed to have it in place, and then to manage sort of outside factors that have taken time to get in place but that we don't have control of has been a challenge. And just linked really to it being a new area for the Trust as well, so for us to try and approach it, as I say, from a provider perspective, but also for our colleagues who are supporting the development to understand and apply that to helping us with the service development as well has been a challenge. So finally, I just want to say that this is a new and exciting area of work for us. For us, it is an innovative and new way of delivering care and provision at home. And we do think that an increase in the capacity of domiciliary care provision in the area will be welcomed. And I will take any questions.
Right, I'll take the first one. Just to say there's a risk that the trust will pay higher wages that other providers will be unable to match. But as they won't receive funding for these services in the way the council does, will it also mean higher prices for NHS services, council services? This could leave patients unable to afford one service and the other service would be unable to attract staff.
I'll try and answer that the best I can. So we have modelled the staff costings across the service for the financial viability. We have also looked at what other providers are paying across the sector and have linked our pay to that. So it's not that our staff will be receiving a higher level of pay compared to the local authority carers or private provider carers. So we don't think that that will be an issue.
Any questions, Councillor Hill?
2 or 3 quick ones again. First of all, is this the plan this would cover the entire Northumberland?
I mean, we are doing it in phases, so we're trying to do it in phases so as we don't destabilise and threaten existing provision, but eventually we plan that we will cover the whole of the Northumbria footprint, so whole of Northumberland and North Tyneside.
So when does it start and which areas will it start in first?
So it has went live yesterday, so it has started, and it has started in North Tyneside, so that the next phase will be to come into Northumberland, in a small area of Northumberland.
Which part of Northumberland?
We are, I think we're being told, what we've done is we've tried to work with the councils to find out where they're finding their pressure areas. So we think in Northumberland it is West Northumberland, so we're going to try and deploy a team there next.
And in terms of recruitment, just to be clear, is this going to be recruitment of existing NHS staff or people that are not currently employed in the NHS, or a mixture of the two?
So the recruitment has went out through the normal recruitment channels, so it is external recruitment, but obviously people internal can apply as well. So it's across. So what we're finding though is we have again been aware of people being concerned that we would, if we advertise these jobs, it would destabilise the sort of current employment. So what we've done some analysis of where people are coming from, and what we're finding is that when I say that people have sort of been devalued as carers, have sort of left the current sector. So some of the ones who are coming back into the current sector to apply for these jobs.
And just finding it touches on what you were asking, Chair. So this is an NHS service, but people have to pay for it.
So it is a commissioned service. So we will be applying to be on the local authority providers list. So the same way the local authorities would commission other care providers, we will be commissioned by the local authority to deliver this work.
Okay.
I've got Councillor Hunter now.
Mine's very similar on the recruitment. Is, are you struggling to find people coming forward to recruit? Because, you know, just about every industry in the country is struggling. And because we often, as councillors, get complaints where people can't get out of hospital, they can't get home because they need adaptations, they need care packages put in. So I think it's growing that capacity without taking staff from, you know, one organisation to another. So just seeing if you have got issues with recruitment.
I would say it has been a challenge, and we are sort of getting to the point now where we are moving through that. I think one of the things that we wanted to have as part of our recruitment was around a career pathway as well. So if people wanted to, like I say, with the sort of role of carers being sort of pressured, we wanted to make sure that if carers wanted to stay in the care profession but were feeling that they didn't have those opportunities, so as the service develops into the phases, we will have more opportunities for that. We like to move into senior carers, supervisors, coordinators, deputy managers and things like that. And then as I think the other side of it is around the career pathway into the wider NHS, and there would be opportunities for that. But again, we're trying to not take all carers from other care providers. I mean, we can't guarantee it, and that's why we're saying we know that it's likely that there will be some disruption. But so far we haven't seen masses coming from any single provider. So it is a challenge for the recruitment, and some of the mobilisation speed has been around the recruitment as well. So it's not without its difficulties, but we think we are working through those and sort of getting into a bit of a rhythm with it as well.
Councillor Bowman.
Staying on the subject of recruitment, how many care workers do you expect to employ in Northumberland, and how many of them will be new to the sector? Are you reaching out for new clients, persons to be employed that have never been in the sector and provide training?
Yep. So in terms of when the service is fully mobilised, we are looking at 250 staff. So we have aligned those to primary care networks. So that we've got 10 primary care networks in the area. So 10 teams of 25 that would deliver. I can't remember off the top of my head, sorry, about how many's in Northumberland, how many's in North Tyneside, but it is the full 10 primary care networks. We are looking at attracting new people into caring roles. The Trust has a widening participation strategy, and as part of that widening participation strategy, we are looking at people who don't have any sort of work experience or anything like that and are wanting to sort of like an entry-level job to get that experience. And we're also working really closely with the apprenticeships team, so to look at school leavers and people like that who might want to come into care as a career. And we're also working with the Department for Work and Pensions around sort of people who are unemployed and are looking at coming into, like I say, a role that they can come in, have the induction and training programme, and progress either as a carer or depend what way they want to progress their career as well.
I've just got another question here. The presentation emphasises home care for people discharged from hospital. Is it the Trust's intention only to provide home care to support hospital discharges? If so, does that mean that the service will only provide people with support for a limited time?
So I suppose the short answer is no. It is not just for a hospital discharge. So I said, obviously, when I was given the presentation, it is also for people who are at home in the community who need care. This is different, and this is the message that we need to get out in our communications as well. So the Trust has obviously done previous work where it has been, up to a short period of time on discharge, but this is a different service. So this is long-term packages of care. So for as long as the person needs it, the care package will also be able to be adjusted as the people's needs change to make sure that it meets those needs. So we don't. It's not a short term, and it's not solely focused on hospital discharge.
It's also would be available for those who, as with all the other providers out there, a number are funded, a number are self-fund, and the same would apply to this. So that it's exactly the same as all of the other care providers in terms of the scope and the length of the service.
Presentation. I just understand that the NCC officers are a bit. They have their concerns about this potentially destabilising the current market. Hopefully that doesn't happen. And just to say that, good luck, and I hope it does work. And we would love to work with you in the future. Thank you. Thanks very much for that. You can stay or you can go. It's up to you. Right, thank you very much, thank you. Move on, we've got number 8, we've got the complaints annual report from 21 to 22, and I believe this is James Hillary.
Yes, thank you very much, Chair. What I was going to do was just talk through some of the highlights in the report, and then if anybody has any questions, by all means ask. So yes, this is the annual report for 21-22, covering the adult social care complaints, as well as the small number of Cxc funded complaints that we get each year and that we respond to on behalf of the CCG. In terms of the complaints that we've received over 21-22, there's been an increase in social care complaints, but a small decrease in Cxc complaints. And as you can see from the report on pages 4 and 5, you can see the numbers of complaints that are upheld or not upheld, partly upheld over the past 2 or 3 years. Just for information, in terms of other outcomes, at the top of page 5, other outcomes can be things like the complaint is withdrawn, or the complaint can't be determined by the manager who's trying to resolve issues. In terms of the services that are being complained about and that we've responded to over 21-22, the bulk of complaints sit with care management, but in the context of the work done in adult social care, that's to be expected. We've also seen an increase in complaints about independent providers, but I'll touch on that a little bit later when we come to outcomes. Pages 6 and 7 just touch on the different subject areas that that we can broadly put a complaint into. Each complaint might have several elements, but we tend to pick one subject that might be the main thrust of the person's complaint, although they might have several other sort of less important or sort of minor issues with that. There's a section on Cxc complaints, but I'll just skip over that because the numbers that we've responded to are very small this past 12 months. In terms of learning, I put a table on page 9 to give an indication of, in broad brushstrokes, the kind of responses that we might make to complaints that we uphold or have some upheld element within them. But the aim of the complaints process is to, in part it's to learn from complaints, and in part it's to make sure that we put things right for the individual who's come to us, and to try and resolve things to their satisfaction, which happens in many cases, but not all cases. Sometimes that we might not be able to do that for a person, and they obviously have the right, if they wish to do so, to progress their complaint to the relevant Ombudsman. The thing that I'd highlight is some of the categories that we've had over 21-22, and on page 10 there's a paragraph about that. But there's things like the standard of service provision, issues around communication and disagreements, and that, if you like, grouping of complaints over 21-22 has, alongside other information, has led to an ongoing, or a piece of work that's ongoing currently, to make sure that relevant staff are clear about their role and the expected standards that we have in adult social care, that the client and their family receive the appropriate information at the right time in their journey with adult social care. And also particularly around charging, because charging can be an underlying theme for people, particularly as I think people, rightly so, expect high standards and value for money. Anyway, I've also included in the learning element chapter, some thumbnail complaints that we dealt with to give a flavour of the kinds of issues that people might have raised over 21 and 22. The other thing that I'd say, just in terms of independent providers, in terms of the numbers, I think when COVID first hit the country in 2021, that an awful lot of people understood the challenges that care providers were having to deal with, and we subsequently got less complaints about independent providers. Whereas I think over 21, 22, that we've kind of gone back to a bit more normal, business as usual, shall we say. So in that sense, the complaints we've had about providers have increased. The other thing about independent providers is that we receive regular data from them around their complaints and their compliments, so that through the contracts and commissioning team with whom we have a close working relationship, so that we're sharing information both ways and taking action as and when we need to. The third section is about Ombudsman complaints. That starts on page 15. Historically, we've had, 6, 7 or 8 complaints a year, but that might be increasing. But we'll have to keep an eye on it, and we'll see, because it might be that people have higher expectations of services. Contributions towards services can be an issue for some people in some circumstances, and as I said earlier, charges can be an underlying sort of concern that people might have when they do make complaints. So the third section has that summary of the different complaints that the Ombudsman or the different Ombudsmen have given a decision on over 21, 22. The fourth section on page 21 deals with inquiries, the vast majority of which we deal with the team in partnership with local social work teams, or whoever it might be that the person's inquiring about. And often these contacts can be, if you like, complaints in the offing, and if we can resolve these quickly and promptly, then we can, I suppose, put things right for the person at a very early stage, and we're reasonably successful with that. And as you can see, we have a number of inquiries by service area in that section. I've included section 5 on compliments, just to sort of offset the complaints. I think in general terms, in the context of the work that's done in adult social care, most people are satisfied, if not very satisfied, with the service that they receive, and it is quite a small minority of people who are deeply unhappy and unable to get a sort of a resolution locally, so they want to make a complaint about that. A little section on advocacy for those people, and we look at that on a case-by-case basis with each individual that might make contact with us. I've made some conclusions just on future plans for the complaints team. The appendices are giving an idea about the processes that we use to deal with complaints, and I've also included some equalities information, but I would be loath to draw any conclusions from the equalities information, basically because the sampling, if you like, of what we have from a complaints point of view is so small compared to the overall numbers of clients and work that's done across adult social care. So from my point of view, if anybody has any questions, I'm more than happy to try and answer them as best I can.
Councillor Patterson and then Councillor Hunter.
Thank you, Chair. Thank you very much for quite a detailed report. I do appreciate that, and it's nice to know what complaints people do have and how we're dealing with them. I wonder if you could just tell us how many thousands of people we do look after under adult social care?
Neil might be better placed than me, but it's around about 7,000. We might be just slightly over 7,000.
Yeah, it's around about 7,500 people that are open to adult social care, and about 5,000 people have packages of care from us. So, and that's against around about 50 complaints in total for last year.
Thank you. I just wanted to put that in context.
Yeah. And
thank you.
I think there might be, is it 2,000 or 3,000 carers? Yeah, as well. The people that we've kind of formally recognised as carers.
Thank you very much.
Councillor Hunter.
Thank you, Chair. Yes, it's handy to know the figures because it just shows that it's not a lot of complaints, because reading it just by there it can seem a lot. When you get these complaints or even compliments, do you feed that into the regular training so that, because we can all learn by, you know, if somebody's got it wrong, it's not identifying somebody as you've got it wrong, but it's so that we can put it right so that hopefully it doesn't happen again?
Yeah, if I can pick that one up.
Yeah, sure.
Yeah, I mean, absolutely. I mean, that's the whole point of the complaints processes that we learn from it. It is fed back through the system. Sometimes it's about an individual and the way an individual officer has behaved in a particular situation, in which case it's education for them. If it's a wider ranging issue, we will perhaps amend procedures, we'll perhaps have a look at what's going on, and we'll spread that across the wider staff groups. So, I mean, it's an absolutely key tool for us in terms of constantly improving performance and quality in terms of what we're trying to do. So yes, we do.
Councillor Hill.
Thank you. When we had this report last year, I mentioned, and others had similar experiences, and it was picked up in some of the complaints around the financials. And I've had residents who've complained along the lines of, you know, the father or the mother was in care and it wasn't explained properly, and as well as the costs, the stress of them dying and so on, they've ended up having to sell the house and so on. And it was agreed that, I don't know, maybe it's a British thing, people don't want to talk about the finances or don't make it clear, but just, and we talked about the need for training and everything. So has there been any signs of improvement of that over the last year that just make it really clear and transparent about what all the financial repercussions, that's the right word, but the cost of the care?
Yeah, you're right if I pick that up.
Oh, sure, Neil, that's fine.
Yeah, I mean, we need to be realistic. Charging is the most contentious issue we deal with, you know, because the NHS is free at source in terms of, and I have to admit, one of the concerns I have about the previous model is whether people will be confused that NHS carers are coming out with an NHS badge on, but then you have to pay for a service. We'll have to work with the trust to try and get communication right on that. I think that will always be the case, Councillor Hill, in terms of charging. Be that, I mean, we do constantly reinforce with teams that they need to be clear with clients, with their families, etc., what the charging situation is. The other problem we have, though, is social care charging is incredibly complex. I mean, it takes us around about 6 months to train a FABO to be able to do the assessments. Because there is such a level of complexity linked to it, and that makes it. I mean, if anybody's got the time, where I can share the information sheet that we give on charging, and that's trying to make it as simple as is humanly possible for people, and it's still complicated. So I think we have to inevitably accept that for some people they will struggle to understand that, and some staff will struggle to explain it as well, and we're constantly trying to refine that, and we work with the staff where we know we've had repeated complaints on charging. The ones I really get frustrated about within our teams is where we have people who claim they've never been told about the charging at all. You know, they weren't aware that they would have to pay for services. That can sometimes, I don't want to be disingenuous to people, but that can sometimes be convenient, and you know, we have evidence on file that they have been told, but in terms of where we're at, other times we don't have that evidence, and we have to work hard with teams to make sure they record that. But I don't think we'll ever get away from that. I mean, charging reform is coming in next year, and if that goes ahead, there will be a change to the system of charging, and quite a fundamental change to the system of charging, but it won't go away completely, even at that point. And there is a risk it will make it slightly more complicated again, because from next year, if that goes ahead, you'll rack up credits against an eventual ability not to be charged for the care component of your adult care. So there's a further layer of difficulty that we're going to have to unpick with that. So we try, and we will continue to try to make it as simple as we can for clients and their families coming into the system, but it's really complicated. I mean, there's just no way around that.
Councillor Dodds.
We've got Derry Nugent as well wanting in, but is this ambulance chaser territory, or do they stay well away from this? You know, the solicitors, no win, no fee. Because when I read all the complaints, it was either someone elderly was confused and hadn't had stuff, and he had, no, it was confusion, which is where we will be at that age type thing. But then there was others in there that were talking financial stuff. Do you get solicitors chasing things, or is that just not? There's not enough in the system.
I think in terms of claims, that's a completely different process. So if someone wanted to make a claim against the council, then they would have to go down a different route, not the complaints route. And obviously, if people did want to make a complaint, our advice would be get a solicitor, whether it's a no-win, no-fee solicitor or a sort of a more traditional solicitor, that would be fine. But I think from a complaints point of view, if we get third parties making complaints on behalf of clients, then we want the client to give us their written agreement that they're happy for this person to represent them and they're happy for us to share their information with them. But in terms of your point about solicitors, we get virtually no solicitors. The overwhelming majority of third parties are family members. And if we were to get contact from solicitors saying, you know, I want to make a complaint on behalf of my client, we'd follow our process, which is, can we have your client's consent so that you can represent them to make a complaint, and that we can share their information with you if that's what you want us to do. It might then follow from that. There's always a risk that a solicitor might go, well, thank you for the response. I'm now going to make a claim against the council. But we do have a quality assurance process to make sure that we are open and honest with the person and that we give as full a response as we possibly reasonably can for that person. So I think the number of claims that we've had on the back of complaints that I'm aware of one from Children's Services that dates back to 2009. So in that sense, we don't get, as far as I'm aware, any particular claims made against the council following a complaint response.
Councillor Bowman.
Thank you, Chair. My question's just been asked. But can I raise another issue? Talk about present day, the increases in living cost and the pressures upon families and individuals. Is that having an impact? I know it's not related to complaints, but is that having an impact on the services now? Are you finding that individuals and families are not able to cope with the finances that they're having to pay for this service?
If I come in on that one, James. Yeah, I mean, I think it's too early to say that we're feeling an impact within adult care per se. I mean, we're certainly feeling an impact in adult care as a purchaser of services from the independent sector. You know, and rising energy costs and things like that affect care homes. You know, the current staffing crisis that we have is affecting dom care providers, as we've heard previously. But in terms of clients approaching us, there isn't a significant feel that is worsening at this point in time, but we are already just entering winter at this point. The temperatures are only just starting to drop a little bit, and I'm not really sure how that will play out at this point, and it's probably impossible to model because we're in an unprecedented situation at the minute with where we're at. So I wouldn't necessarily rule that out.
I was just going to add, Neil, that from a complaints point of view, if someone says that they're struggling, hypothetically, then our advice would be to talk to the finance team about the difficulties that person might be having at that point in time around payment for care, and to try and resolve things, if you like, with the finance team, who, in my experience, have always been very understanding when people find themselves in financial difficulties.
Debbie, did you want to ask a question?
Yeah, just quickly, actually, more of a comment than a question. I found the report really refreshing, and I think I welcome the transparency. So I think from Health Watch's perspective, where people have concerns, if they're able to raise them and see a result, that is always welcome. And I think what I was particularly taken with was where the willingness to make an apology. And I think in a number of the examples you've given, you said, apologies were given, and not just once or twice or whatever. So I think that was very welcome. And I think I'm also heartened by what Neil just said about the training that you've given staff off the back from the learning from the complaints, because one of the things that you'll all be aware of from a recent report that we did with people who are using home care services is sometimes they don't feel that they want to make a complaint. There's that reticence. And so I think knowing that where people do make a complaint and there's learning across the board actually helps those people too. And I think that's really, really important. And I just think it fits for us. I think if people don't feel able to make a complaint, that's okay, that's their choice. But it seems that you're very willing to receive complaints or concerns. That's the impression I get. Would that be a right thing to say?
No, absolutely. I mean, if we take scale, we are a £200 million service dealing with 7,500 clients. We've got in excess of 1,000 staff directly employed and God knows how many thousand working within the independent sector as well. It's inconceivable that we won't get things wrong from time to time with that scale of operation that we're working with. And I would agree, Derry, it's absolutely critical that we don't repeat issues and we don't repeat problems, and that's the key thing. We're dealing with people at the most vulnerable time in their lives. It can be end of life that we're dealing with. It can be disability that's come on over a period of time, or disability that's come on suddenly via a traumatic incident or whatever. Families are stressed through that. Clients are stressed through that. We will not get it right every time, but we will try our best to get it right as often as we can with that scale and backdrop.
Okay, is there any other questions? No? Well, just thank you for that report, and it's great to see that there is open and transparency here, and that how we deal with things is absolutely great, but thank you so much for that. Thank you. The next one is the Health and Wellbeing Overview, the programme, which is Chris.
Thanks, Chair. There was a report due, I think, next month on the Specialist Dementia Service. This was a report that went to Cabinet a few months ago, and it was agreed that it would come back to this committee as an overview exercise. After discussions with Neil and his team, it wouldn't be the right time for that report to come back. So it's been deferred until June, which officers feel is the most appropriate time for it to come back to this committee to give that committee the best overview of how that service is going. That was the only thing I wanted to say on the work programme, but obviously, as always, if there's anything members want to add. Councillor Hill.
Councillor Hill.
I was just going to ask, I don't know what the timescale would be, but I presume I think we all had concerns and a number of additional questions really about the home care. I presume, I don't know if there's a set date, but that would be in mind to be an update on that.
Yeah,
particularly when it gets started.
I think an update on that would be good. We just need to decide when that would be with the trust.
Yeah. Yep. That's agreed. Isabella Hunter, Councillor Hunter.
At some point, an ambulance update as to, because the situation they've been going through, I know they're talking about possible strikes and things like that, so I'm not quite sure where the appropriate time would be to ask them to come back to us.
Is urgent business. I've only got one. It's just to remind all the members of the Tackling Inequalities Conference, which is on the 12th of October, and it'll be in this chamber at 10 o'clock. Just to remind you of that. And the date of the next meeting will be, it's been changed to the 3rd of November, as because the strategic plan's got quite a few planning applications on there, so we've decided to change it to the 3rd. And I think that's it. So thank you very much, everybody, for coming. Thanks a lot.